Holistic Management of Autism current updates, which is in person as well as virtual because of overwhelming, you know, response. So anybody wants, they can log in and they have been already mailed. Those people who are attendees have already got the mails and you can register for this. There's going to be, we have an Indo-Canadian Autism Network. So 3 of our colleagues have come from Canada and will be talking about it. And next weekend, we have the Asian Oceanian Child Neurology Educational Symposium, 27 to 29 September, which is virtual. And you can log in for that as well. You'll have to register on, and if those are members of AOCNA, it's free of cost. And then very importantly, the 17th Asian Oceanian Child Neurology Congress, we have next year, 17th to 20th September. Please block your dates. And we have pre-conference workshops, which will be 6 in number, and definitely one on sleep. So please block the dates. Today, we are going to have a wonderful orator talking on parasomnias, Dr. Sanjeev Kothari, and he's Director of Pediatric Neurology, Service Line for North Hill Health, Professor of Pediatrics and Neurology at the Zucker School of Medicine, New York, and he is MD, FAES, FAAN, and FAASM. And he's editor of Sleep and Childhood Neurological Disorders, Parasomnias, and Sleep Disorders in Adolescents, and associate editor of the Journal of Clinical Sleep Medicine, and section editor of Pediatric Neurology. He has over 200 publications and over 50 review articles and 50 chapters, and he's recipient of the Harvard Catalyst and several R21 NIH grants in the past. And experts we have is Professor Suresh Kauttagal, who is pediatric neurologist and sleep specialist in Mayo Clinic, Minnesota. He's I just recently superannuated from there. And he is has been his MD and MA, and he has at sleep medicine. He's with special interest with focus on childhood narcolepsy and sleep in children. And he's working a lot on sleep in neurodevelopmental disorders and basically all aspects of sleep. And achievements have been, he's been director of number of MN annual meeting courses and twice as director of the neonatology neurology course. He's member of the pediatric working group on the international classification of sleep disorders. And in 2013, he received the Excellence in Education Award by the American Academy of Sleep Medicine. We have Professor Shelley Weiss. She's professor, Faculty of Medicine, University of Toronto, a pediatric neurologist at SickKids Toronto, Ontario, Canada, and chair of Royal College of Physicians and Surgeons of Canada Education Committee for the Canadian Diploma in Sleep Disorder Medicine. She's MD FRCPC, and her research areas and expertise have pediatric epilepsy, epilepsy surgery, and pediatric sleep medicine. She is past president of the Canadian Sleep Society and past member of Governing Council of World Sleep Society representing North America. Professor Ebru Arhan, thanks for joining again, Professor Ebru. She is from Department of Pediatric Neurology, Gazi University of School of Medicine, Turkey, and board member of Turkish Child Neurology Association, and co-leader in the pediatric epilepsy subsection of the Gazi University Pediatric Neurology Department Epilepsy Center. And her areas of interest are epilepsy, including dietary therapies and intractable epilepsy, neurostimulation, epilepsy surgery, and sleep disorders, and has more than 100 research publications, and is an editorial board member of Archives of Epilepsy and many other journals. And she's a trainer for postgraduate diploma on epilepsy and faculty of the EEG workshops and epilepsy teaching programs of the Turkish Child Neurology Society. And we are very happy to have Dr. Ahmed Virk, who's an assistant professor in the Children's Hospital and Institute of Child Health, Faisalabad, Pakistan, who's FCPS Pediatrics and FCPS Pediatric Neurology with area of interest in pediatric human disorders and also sleep, and has many international and national publications, has established pediatric neurology and neurophysiology in department at the Faisalabad Children's Hospital. And co-moderator is my colleague and who was my student earlier, Dr. Vishwarup Chakraborty, who is currently additional professor in the Child Neurology Division Department of Pediatrics, and he did his DM from us, our division, and as alumnus from here, and currently as a faculty and teacher here. His areas of interest are pediatric sleep, neuroimmunology, neurocystic cirrhosis, status epilepticus, and drug-responsive epilepsy, and he has many projects. To his credit, he's been leading lots of projects, 5 in number till now, many publications and chapters and books, and was awarded AIMS Research Excellence Award for 2020-2022. And awarded also the All Presidents AOC and Young Investigator Award in Child Neurology last year. So over to you, Vishnu. And we would be having the talk by Dr. Kothari, followed by expert opinions. Then we are going to be having three very brief, quick cases by three early career researchers there. Very brief three cases. And we have a total time till for 90 minutes. And I think, yes, so we have 85 minutes left. Thank you so much, Dr. Vishnu.
Thank you, ma'am. So without any delays, so over to you, sir. Dr. Kothare, sir, we are all looking forward to this talk. And so for the next one hour, we are all looking forward to your talk on parasomnia. I also had this wonderful opportunity to be at sir's clinic for 2 weeks this year. And I must tell you, it was one of the most fruitful, teaching and learning experiences for me. So over to you, sir, for your talk.
Something. Okay. Thank you, Dr. Gulati. Thank you, Dr. Biswas, for those nice comments. And it was a pleasure having you when you were here with us in New York. So I'm going to be talking for the next about 45 minutes on parasomnias in children. And I have no conflicts of interest for this talk. Here are my learning objectives: to know the prevalence of various parasomnias, to be aware of the differential diagnosis of these nocturnal events, and to be knowledgeable on developing strategies of diagnosing and managing various parasomnias. I will be talking on the definition, pathophysiology, and classification of parasomnias, discuss some interesting parasomnias, talk about parasomnia mimics, and then finally management of parasomnias. So what are parasomnias? These are undesirable physical events or experiences that occur during entry into sleep, within sleep, or during arousal from sleep. They encompass abnormal sleep-related complex movements, behaviors, emotions, perceptions, dreams, and autonomic activity resulting in sleep disruption, adverse health effects, untoward psychosocial effects, and resulting injuries. So why do they happen? Sleep-wake transition is not a complete on-off switch phenomena, but a period of gradual transition. During this period of reorganization, parasomnias occur due to a dissociation of sleep-wake transitions. So the International Classification of Sleep Disorders, 3rd edition, has classified them as non-REM parasomnias, which include confusional arousals, night terrors, sleepwalking, and sleep-related eating disorders; REM parasomnias, which include nightmares, REM behavior disorder, and recurrent isolated sleep paralysis; and other parasomnias, which include exploding head syndrome, sleep-related hallucinations, sleep enuresis, parasomnias due to medical disorders, parasomnias due to medications and substance abuse, and parasomnias unspecified. And finally, variants include sleep talking, which is truly not a parasomnia, and overlap parasomnias, where you can have same patient getting non-REM and REM parasomnias. So I'd like you to focus on this cartoon where in children, the first non-REM cycle is pretty deep and long. So it's about almost 90 to 120 minutes. And then it's followed by REM and then another non-REM cycle. And this goes on so that in the first half of the night, there is more non-REM sleep. In the second half of the night, there's more REM sleep over here. And that's why you get more non-REM parasomnias in the first half of the night and REM parasomnias in the second half of the night. Compare that to young adults. The first non-REM cycle is not that deep and not that prolonged, and therefore non-REM parasomnias don't exist so commonly in young adults. What are the factors which precipitate disorders of arousal? So sleep deprivation. If you get forced arousal from sleep due to either a noise, a full bladder, or pain, you can have circadian rhythm disorders in which you have difficulty with sleep onset and sleep maintenance, fever, infections, many medications. Sleep disorder breathing is an important cause. Snoring and sleep apnea can arouse you out of sleep. Periodic leg movements and restless leg syndromes, stress, and even the menstrual cycle can give you disturbed sleep. And obviously, genetic factors are very important. If the family member, the mother or the father had it, the kid more likely is going to have the same thing. So the key features to disorders of arousal are that mostly they happen out of stage 3 sleep. They're seen in the first third of the night. They're more common in children. They decrease in frequency with age. There's poor recall of the event. and the events have varying behaviors and they are not stereotypical. They can be waxing and waning and prolonged. So here's the first one, confusional arousals. So these are behaviors that happen during or after arousals from sleep. They occur most often out of stage 3 sleep and during the first third of the night. The prevalence rate in children is 3 to 13 years of age, with a prevalence of about 17%. In children older than 15 years and in adults, the prevalence can be as high as 7%. In most cases, patients outgrow the problem. And so here's a patient of mine who had these behaviors. He was on lamotrigine for mood stabilization, and he would get daily events which would happen as he was falling asleep and sometimes as he was waking up. And you can see what he does. He wakes up out of sleep and he does this bizarre posturing of his extremities. And this goes on for about a minute. And then he has this retching, what we call as ictal vomiting, and then opens his eyes and does even more bizarre behaviors. You'll see in a second. And the mother notices something is going on. There you go. So
Seems to have anesthesia.
and the EEG did not show any epileptiform activity, just muscle and arousal.
Seems to have anesthesia.
And you can see these flailing movements of the extremities. And then it's all over. So many years ago, tonic his upper extremity movements were. And this was thought to be a parasomnia, but later on, Dr. Berkowitz and several people in this group from Canada, from MNI, Montreal Neurological Institute, described with the help of depth electrodes that this was a frontal lobe epilepsy. In this case, we decided to do an ictal SPECT, which picked up a focus in the right frontal lobe. And after resection, his seizures completely disappeared. Ictal vomiting often localizes or lateralizes at least to the non-dominant hemisphere. So this is an example why it's important to differentiate confusional arousal from frontal lobe epilepsy. And here's how we differentiate between the two. In frontal lobe epilepsy, the multiple episodes can happen in the night, and they're often brief. They're stereotypical, while in non-REM parasomnias like confusional arousals, they are more non-complex. I mean, they're complex, but they're not stereotypical. And again, frontal lobe epilepsy happens in stage 2 sleep. Arousal disorders or confusional arousals happens in stage 3 sleep. And there is a FLEP scale that is used in adults, which I'm not going to talk today because that's more relevant to adults. Here's another case. And here I have an EEG running along with this. And you can see he has the similar posturing, almost bicycling movements of his extremities, lower extremities, fumbling of his ear, and then nose rubbing. You can see the EEG does not show a seizure. So is this a seizure or is it a parasomnia? And why is it important? And why is it so difficult to differentiate between the two? Because you can see there are certain aggregates of neurons called CPGs, these CPGs, they are called central pattern generators. These CPGs are located in the frontal lobe, in the basal ganglia, in the thalamus, in the brainstem, in the cerebellum, and even the spinal cord. And these get activated both in a parasomnia as well as in frontal lobe epilepsy. And therefore, they give a similar expression that you saw both in a parasomnia and in a frontal lobe epilepsy. And therefore, it's difficult to differentiate between the two. Now, more importantly, to complicate the problem, you know that arousal disorders or parasomnias are caused due to a cholinergic mechanism. You also know that frontal lobe epilepsy is caused due to the nicotinic acetylcholine receptors. And so therefore, parasomnias and frontal lobe epilepsies can coexist. And I would propose that almost a third of patients with frontal lobe epilepsy often have parasomnias. So the learning and teaching point over here is if you have a patient whom you have diagnosed with nocturnal epilepsy and he's on medications, and he calls and says, I have more events, don't assume that they are frontal lobe or they're more worsening of seizures. They could be parasomnias also, oftentimes bringing them into, and it's unclear whether these are seizures or they are moments in which you can see these patients have this kind of a movement disorder, and it's unclear whether this is another case of some kind of a paroxysmal movement disorder or some kind of an epilepsy, but they respond very well to very low doses of carbamazepine or oxcarbazine. So again, another thing worth considering. In general, here's a nice cartoon. The Australians have been very prolific in parasomnias. This is an article by Derry et al. From Australia, where you can see that any stimulus, whether it's physiological or it's a pathological like a seizure, gives you an arousal. So eyes open, head gets elevated, you're staring and you look around, and then you can either go back to sleep or you can have a parasomnia, like a confusional arousal, or you can have a clinical seizure. So this is a cartoon very nicely explains, and you can have both at times. Sometimes this, and so it's important to know this cartoon well. So here's another case, and this is an example of, watch carefully here when this generalized spikes comes up. So during this generalized spike, he gets a myoclonic jerk. Now, in this case, he went back to sleep, but he could have got up and had a sleepwalking or a confusional arousal, or he could have a seizure. So this is the cartoon to explain. This is the video to explain that cartoon. And again, the same group has published that what are the factors which favor parasomnias: yawning, scratching, nose rubbing, rolling over, waxing and waning cores, prolonged episodes more than 2 minutes are more in favor of parasomnias. While features which do not help to differentiate between the two are short episodes, just sitting up, standing or walking, and brief ones, 10 seconds, there could be either, and fearful expression could be either a seizure or a parasomnia. Next, night terrors. So these are sudden arousals from stage 3 sleep. They're associated with intense autonomic and motor symptoms such as crying or screaming. These events can be dramatic and disturbing to the family, yet the patient may be unfazed by the events. They're common in children, occurring in up to 6% cases, and the prevalence in adults is about 2%. So in this, what happens is that during slow wave sleep, there's a sudden arousal. This leads, the patient just sits up and screams. There's an expression of panic. There's tremendous autonomic discharge with change in the blood pressure, heart rate. They are confused, disoriented. They do not respond to the parents. There's mumbled speech, and any attempt to wake them up leads to more confusion. And there's complete amnesia of the event. So that's a classic for night terror. And here's a patient who you can see is having a night terror. So he's sleeping over here, and then he wakes up, and he has these intense screaming episodes. The best thing to do is to just put him back to sleep. Do not try to wake him up. Just put him back to sleep and he will fall back to sleep. So that's a night terror. Sleepwalking. So sleepwalking is an arousal disorder culminating in walking around in an altered state with impaired judgment. It occurs most often out of stage 3 sleep and during the first third of the night. And obviously, safety and legal implications have to be addressed. In adults and in older teenagers, there have been some criminal activities, some violence during these sleepwalking, and it becomes part of forensic psychiatry and sleep medicine to differentiate for the courts whether the event was a sleep disorder or was it volitional, and the person did it in an awake state. Safety also is important because they can jump out of windows, they can fall down staircases. I've had patients walking outside their house in the backyard or on the road. So it's very important to keep the house safe, keep the kitchen locked because they can light up the stove and create fires. So this needs to be differentiated from, again, frontal lobe epilepsy. And the prevalence is as high as 17% with a peak age at about 12 years, and typically decreases in frequency until adulthood, but 3% of adults continue to sleepwalk. It fires. So this needs to be differentiated from, again, frontal lobe epilepsy. And the prevalence is as high as 17% with a peak age at about 12 years, and typically decreases in frequency until adulthood, but 3% of adults continue to sleepwalk. sleep talking. This is a benign variant of a parasomnia, and it's very common in children and adults. So here's a guy, you can see what he's doing. Again, out of slow wave sleep. And he gets an arousal and he's talking. The audio is not coming along well, but you can see him, he's mumbling something. So that's a sleep episode of confusion arousal with sleep talking. Sleep-related eating disorder is a very interesting condition. So this consists of recurrent episodes of involuntary eating occurring during the main sleep period. This disorder typically involves eating peculiar forms or combinations of food, especially dangerous or toxic substances and fatty food. Like disorders of arousal, most patients do not have full recall of the event. Eating can occur multiple times in one night, typically with high caloric food. And this is commonly associated with sleepwalking and restless leg syndrome. This should be distinguished from night eating syndrome, which is characterized by a full recall of the event and absence of bizarre or toxic ingestion. So in sleep-related eating disorders, it happens out of sleep and they do not remember anything about it. It may be precipitated by patients who use sodium oxybate for narcolepsy or SSRIs like Prozac. And the treatment for that would be to use a dopaminergic drug for restless leg syndrome, so something like Mirapex or gabapentin for treating it. Unlike that, sleep eating disorders is an association disorder where they have to eat food to fall asleep. Some of them have to smoke to fall asleep. And in them, using clonazepam may be more useful to decrease that association. So nightmares. Now we're moving to REM parasomnias. So 10 to 50% of children are affected by nightmares, and up to 75% of the population can remember at least one or a few nightmares in the course of their childhood. The frequency of nightmares experiences increases in patients diagnosed with PTSD, those underlying medical procedures, and in those with psychological stress caused by major catastrophic events. And he's saying of these angels who came from the sky to meet him or something of that effect. So that's his dream, which is a height of 10 feet on a concrete block. And because of that, had CT scans of her whole body. And a thyroid nodule was found. She was told that she had thyroid cancer. And then she started having, within 2 weeks, these daytime and nocturnal events, which were thought to be seizures, because they thought this was post-traumatic epilepsy. She was put on Keppra and with no response. And then she came to see me for a second. She's awake, she's on the computer, and then suddenly she gets an aura, and then she has this bizarre movement, which was thought to be a seizure. Clearly, the EEG did not show any epileptiform activity, and the clue that this is not a seizure is what she does now. What she's doing now is trying to help putting her clothes in place, clearly showing that it is volitional and it was not a seizure. So her eyes were closed, not open, showing that this is not a seizure. And then she has a second episode in sleep, again, this time out of REM sleep. That's the mother sleeping over there on the side, and that's the kid. And she gets a bad dream where she does this behavior out of REM sleep, which was again thought to be nocturnal seizures, clearly not showing any epileptiform activity during the event. So clearly showing that this was a dream mentation disorder, what we call as REM-related arousal. And oftentimes patients who have an underlying anxiety express themselves in the night with nocturnal panic attacks and anxiety disorders. Next, REM behavior disorder. This is a very interesting disorder. This is classically seen in men over 50 years of age with a prevalence of 0.5%. This is characterized by complex motor activity associated with elaborate dream enactment, which corresponds with the dream sequence. Often it is the injury to the self or bed partner that brings the patient to the attention of the clinician. This is accompanied with lack of REM atonia. Normally you have REM atonia, and here there's lack of REM atonia. And the treatment often involves using melatonin and, in rare cases, clonazepam. In adults over 50 years of age, it is a precursor to Parkinson's syndrome. And in young adults, it may also be caused by chronic alcoholism, brainstem tumors, MS, and SSRI use. In teenagers and young children, it has been associated with narcolepsy, SSRI use, and he's trying to attack that unknown entity. He kicks and punches. Obviously, his spouse refuses to sleep with him because she has got injured by him during this violent, bizarre behavior. So this is a classic example of REM behavior disorder. If you do their sleep study, you will find that during REM sleep, you can see the rapid eye movements. So that's lack of REM atonia, and this is classically seen in REM behavior disorder. And the mechanism is related to the reticulospinal tract, which normally sends input through the brainstem into the spinal anterior horn cells, causing REM atonia during REM sleep. In REM behavior disorder, there's a lack of medullary mediated spinal motor neuron inhibition, which leads to the lack of REM atonia, which leads to REM behavior disorder. So again, this is a differential between nocturnal frontal lobe epilepsy, non-REM parasomnias, and REM parasomnia. These are available to you because this is being recorded. So you can go over this table because it's very nicely describing the difference between the three. And how do we treat the REM behavior disorder? The first line treatment is to use melatonin. So 3 to 5 milligrams of melatonin, half an hour before sleep onset, hopefully should suppress the REM behavior disorder. But in case where you cannot get suppressed with melatonin, you can try clonazepam. And for some unknown reason, clonazepam works better than any other benzodiazepines in REM behavior disorder. And a small dose of 0.5 to 1 milligram is more than sufficient. But people have to use Zopiclone and many other products over here, which I've shown over here. Isolated sleep paralysis is an interesting condition. The inability to move on awakening at sleep onset or on awakening, this is not uncommon. And as I shown over here, about 50% of normal people have experiences at least once in their lifetime. I have had many people in the hospital come to me and say, I woke up this morning as if somebody was breathing from the back on my back, and I couldn't move at all. It was very frightening. So the sufferers recall a frightening arousal during which they experience paralysis of the skeletal muscles, with the possible exception of the respiratory and eye movements, although cognition remains intact. The episodes generally last a few minutes and improve spontaneously or on external stimulation, and reassurance is all that is needed. Now, this is a very interesting condition, catathenia. So this is characterized by expiratory groaning during sleep. The events usually occur nightly and during REM sleep. Patient does not show emotions or respiratory distress, but does not recollect the event. You need to do an ENT evaluation to rule out vocal cord paralysis. This needs to be differentiated from central sleep apnea. And they usually start in the late teenage years with a prevalence of 1%. And in case when it's really disturbing with causing fragmented sleep and disturbing to other family members, CPAP can decrease the intensity and frequency. So this is exactly how it appears, or how you hear it. You feel it is a snoring, but it is not snoring. It's expiratory. Exploding head syndrome is another interesting condition. This is characterized by a sudden loud noise or sense of explosion in the head, either at sleep-wake transition or an awakening during the night. The noise can be a loud bang, explosion, or a crash of cymbals, but sometimes it can be less dramatic. Patients are typically frightened by their symptoms and concerned about an impending serious health problem. The myoclonic jerks and flashes of light may accompany the sound. They occur more commonly in women with a median age of onset of 58 years, but can be seen in teenagers also. The epidemiology and pathophysiology are unknown, although they are believed to represent a variant of a sleep start, like hypnic jerks. The condition is rarely treated because of its benign nature, but clomipramine, nifedipine, and topidamate have been used. Bruxism, everybody knows these are kids who grind their teeth. When you do the sleep study, you can see this EMG artifact on their sleep study. This is how it looks. And these patients, because of very fragmented sleep, because of the bruxism, behave like ADHD in the daytime. So be aware that when you have ADHD-like symptoms in the daytime, please inquire about sleep for bruxism and for restless leg syndrome and periodic limb movements of sleep, which can also fragment sleep, giving you periodic limb movement disorder mimicking ADHD. So this is the paper which was addressing the same problem, that bruxism and how they mimic ADHD. So in general, how do you evaluate nocturnal events? A very careful history is crucial. Home videos, everybody has a cell phone which has a video capability. Get them to tape the event. Seeing the video helps you a lot. And then routine and sleep deprived EEGs. Now, what is a sleep deprived EEG? It means that you allow 4 hours of sleep. The way we do it in our lab, we let the kid not sleep that night till 2 o'clock, wake him up at 6:30. Let the parent not let him sleep when they are bringing him into the sleep lab or the EEG lab. Then we get a EEG. What this does is that you know that sleep activates epileptiform activity, and sleep deprivation further activates any epileptiform activity. So sleep deprived EEGs are very, very useful in nocturnal events. And 24-hour ambulatory EEGs can be done. Video EEGs and sometimes a video polysomnography with extended EEG monitors can be done. How do we address patients with parasomnias? I usually get a ferritin level, because if your ferritin is below 50 microgram per liter, you have low iron in the brain, and that could be treated with you giving iron so that your periodic limb movements of sleep reduce. If you decrease your leg twitching, you arouse less, and if you arouse less, you have less parasomnias. You can get a GI evaluation to rule out reflux, a pulmonary evaluation to rule out nocturnal asthma, a psychiatric evaluation for nocturnal panic attacks and post-traumatic stress disorders, and a sleep study to rule out obstructive sleep apnea. And before you start medications, it's important, especially for forensic and legal reasons, you get a sleep study before you're going to start medications. So what are the indications for polysomnography in evaluating parasomnias? If you have a high suspicion for seizures, if the behaviors are violent or potentially dangerous, they have atypical presentation because of age of onset, duration, or semiology, forensic or legal reasons, not responsive to conventional therapy, and if you suspect an alternate sleep disorder, such as obstructive sleep apnea. How do you treat them? Reassurance, safety, legal implications, treat the underlying medical disorder, avoid precipitating factors like sleep deprivation, behavioral approaches like relaxation techniques. There's a therapy called scheduled anticipatory awakenings, where let's say that the kid gets a nocturnal event every night at 2 o'clock. Well, there's one possibility that you wake him up at 1:30, make him go to the bathroom, and then the chances that it will go away because you're not going into stage 3 sleep is likely, but parents don't like it because to wake up every night for an event which may not happen is not very kosher. Then you can use medications like low-dose benzodiazepam, like clonazepam. Sometimes I've used tricyclic antidepressants and melatonin. And here's a patient, this is a video just to show you, reinforce you about safety. So you can see this is a patient who's got a confusional arousal. Had the bed rails not been there, he would have fallen down the bed. So safety is very important. So safety precautions for sleepwalkers: sleep on the first floor, safety gates on stairways, door alarms, secure car keys and weapons, remove oven knobs, clear area out of sleep, usually stage 2 sleep. She would be completely awake oriented and would have complete recall of the event, but she had choking sensation, like a laryngeal sort of a stridor sort of a sensation. And here she's trying to break that event, and it happened many, many times every night. The EEG would not show any epileptiform activity. So an important cause for these nocturnal events could be insular epilepsy, where you have ictal autonomic changes with choking, breathing issues, and autonomic features coming from the insula. So in conclusion, this is a big table which kind of discusses confusional arousal, sleep terror, sleepwalking, nightmares, REM behavior disorders, and nocturnal seizures. I've gone through each one of them. This table is going to be available to you for viewing later on. And in general, it's basically many times an overlapping states where you can have REM behavior disorder, hypnagogic hallucinations and sleep paralysis as REM phenomena. You can have nocturnal frontal lobe epilepsy. You can have confusional arousal, sleepwalking, sleep terrors as non-REM phenomena. You can have sexsomnias where you have involuntary sex during non-REM sleep that happens both in men and women, and it's very embarrassing, but it happens. It's a true parasomnia, carathrenia and sleep-related eating disorders, and you can have psychogenic spells of dissociative disorders and PTSD. And so, in conclusion, parasomnias are abnormal and undesirable motor or verbal events that manifest during sleep or wake to sleep transitions. Features of the clinical history and examination, along with findings from the overnight polysomnography, are essential to differentiate between different parasomnias and their mimics. Disorders of arousals like sleepwalking, sleep terrors, and confusion arousals arise from non-REM sleep, usually stage 3, typically occurring during the first third of the night and usually involve no memory or poor recall of the event by the patient. REM sleep parasomnias include REM sleep behavior disorder, nightmares, and isolated sleep paralysis. They occur out of stage REM sleep and usually involve some recollection of the event or dream content related to the motor activity by the patient. Management of parasomnias include identifying and treating other underlying sleep disorders such as sleep apnea, periodic limb movements of sleep, educating the parents, the patient regarding safety, and possible pharmacological treatment specific to the parasomnia or the associated sleep-related motor activity. And with that, thank you very much for your attention. And if there are any questions.
Thank you, Dr. Kothare, for an excellent, excellent deliberation. You were a wonderful orator as usual. Before we go on to Q&A, I would request our experts to share their views. Professor Kotagal, please, your views.
Thank you, Dr. Gulati, and thank you for inviting me to speak. Sanji, that was a wonderful, wonderful presentation. Expect nothing less than that from you. I would like to point out that when it comes to parasomnias, I suppose one could divide them into parasomnias which are relatively simple. You just got sleepwalking, or you just got confusional arousal, or you got parasomnias that are associated with a comorbid disturbance like seizures or a psychiatric disturbance like anxiety. For those relatively simple parasomnias, we don't need to refer them to the sleep lab. The clinician should be able to get a good history, a good video clip from the family, and just use his or her own judgment to make a decision. But I think where there is need to refer to a sleep specialist or epilepsy specialist is when there is a comorbidity like seizures, or it's just not clear, whether there's some sort of anxiety. So that was my one comment. The other is with regard to REM sleep behavior disorder of children. When we first reported it in 2014, I believe it was, in the JCSM, Robin Lloyd, one of my fellows, was the first author. You notice that there's really no association with any sort of neurodegenerative process. Of course, in RBD in the adults is often associated with a synucleinopathy, but in children, there is no such association, probably of developmental origin or related to medications like SSRIs, etc. And my third comment was about bruxism. If one looks at bruxism as a disturbance of central pattern generators involving the motor nucleus of the trigeminal nerve, a lot of central pattern generator disturbances are associated with iron deficiency. So sometimes, simply checking ferritin and optimizing that might be of help. Certainly, if there is obstructive sleep apnea, as Dr. Kothari mentioned, addressing that will help to resolve the bruxism also. Well, anyway, those are my 2-bit comments.
Thank you. Thank you so much, sir. Thank you. Dr. Shelley, we'd like to hear your comments.
Sure. So I won't echo Dr. Kothari. It was an excellent presentation. I agree with Dr. Kotagal. I just wanted to answer one of the questions that are in the chat because that will shorten the time, make sure all the questions are answered. So the question was about medications for night terrors and sleepwalking. And I'll just reiterate what Dr. Kothari said. So usually when children have these problems, young children, if they're happening often and they're disturbing, there's often an underlying problem like behavioral insomnia, so kids who just don't have sleep continuity, but also you always have to think about emotional disturbance that is promoting these sleep problems. So bullying at school, any kind of emotional problems at home. And when the person, I think it's Dr. Jane, asked about medications, you don't usually need medications because if you can resolve the underlying problem, and also remember sleep apnea can also lead to more of these arousals. If you can resolve the underlying problem, then often the arousal disorder improves. And even if you were going to use a medication, it would kind of be like, I think Dr. Kothari said, it's like a Band-Aid. It's not going to actually resolve the problem. Many young children, when they're not that common, will just outgrow these arousal disorders with age. But I think rather than thinking about medication, the important thing is to think about what is actually promoting more of these arousals, which can be a natural phenomenon in young children. But what can you actually treat in terms of problems that are promoting children to have more frequent and more disturbing arousal disorders. So I just want to, then Dr. Kothari, you have one last question to answer. And thank you for inviting me.
Thank you so much, Professor Rees. Professor Ebru, your comments, because we actually go from various resource settings and we try to have viewpoints from all sides,
Thank you, Dr. Gulati. I'm really very happy to be here this night because, as you know, I also deal with epilepsy and also do video EEG and polysomnographic evaluations in children. And Dr. Kothari, it was really an excellent talk because you all talk about how to differentiate epileptic seizures from parasomnias. As Dr. Kotogalas said, for the benign parasomnias, patients and parents do not have to worry about it. But if there's a suspicion of an epilepsy, particularly the nocturnal frontal lobe epilepsy, which is now named as sleep-related hypermotor epilepsy, as you know. In 2014, it was the name was changed, and it was named as sleep-related hypermotor epilepsy, and abbreviated as SHE. In sleep-related hypermotor epilepsy, the attacks are shorter than parasomnias, especially shorter than 1 minute, and they're always stereotypical. They have some kind of dystonic attacks, some kind of coriform attacks, and they all really are confused as is it a parasomnia or an epileptic seizure? In this form, as Dr. Kotogal has said, really an extremely detailed history should be taken because the parasomnias and the sleep-related hypermotor epilepsy may be distinguished by only the anamnesis mostly. And if the physician has the problem to differentiate with the anamnesis and the detailed history, then the patient should be referred to the video EEG and polysomnography evaluation. With this one, many times the EEG is normal, but with the video EEG recordings and EEG bands and the attacks, we call them sleep-related hypermotor epilepsy. I have a series of sleep-related hypermotor epilepsy, and I'm trying to write them. And if you let us to show these patients, Dr. Gulati will be glad to show these sleep-related hypermotor epilepsy patients. But it's really difficult to distinguish from parasomnias. Thank you, Dr. Kothari. It was really excellent. Thank you.
Thank you.
Thank you, Professor Ebru. Dr. Ahmed.
You're muted. You're muted.
Yes, thank you. Thank you, Dr. Sanjeev, for a very nice talk and very well elaborative talk. And I'm thankful for inviting me for comments. You are rightly said that confusional arousal is sometimes very difficult to differentiate from the nocturnal frontal lobe epilepsy. And in our setting where we don't have many centers available for sleep studies in children, and in those cases, many times we have to give a trial of carbamazepine, and in 10% of the patients, carbamazepine works. So we have seen many cases of nocturnal frontal lobe epilepsy presenting as confusional arousals. Secondly, addition of iron in these parasomnias is very much helpful in our patients, and we strongly advocate our general pediatric colleagues to add iron in any case who presents with parasomnias or other sleep-related disorders. My third comment is that can we add nocturnal enuresis in case of parasomnia? So I would like to have your comments on nocturnal enuresis.
Suresh, what do you think?
Well, that's a really tough one.
That's why
You know-
I turned it to you. I said, I don't know the answer.
You're putting it on me. No, I think that, nocturnal enuresis could certainly occur. It could be an ictal behavior too, because if there is seizure onset is close to the parasagittal region of the cortex, so certainly you could have a situation where enuresis is related to a seizure. So I think when we do the EEG, it's important to make sure that it's extensively, it's covering the entire surface area of the scalp. But I think I have actually seen about 4 or 5 patients, I think 4, who really had nothing but isolated nocturnal enuresis, nothing else. Otherwise, PSG was normal, no other sleep pathology. But it wasn't not happening very often. Only thing is, whenever it happened, the child was very tired in the morning, had a headache, some, sort of quasi postictal type of manifestations. And I believe 2 of the 4 were really from Canada. They had come down and put them on carbamazepine. They did very well and did not have any. So I think certainly it's possible, though it's less frequent. I think more often nocturnal enuresis is sort of a neuromaturational bladder problem, but occasionally it could be an ictal disturbance as well.
I also want to add that in obstructive sleep apnea, you do get nocturnal enuresis. And for the trainees over here, the reason for that is the atrial natriuretic factor is located in the interatrial septum. And with the negative intrathoracic pressure with the obstructive sleep apnea, that gets secreted. And therefore, you get these episodes of nocturnal enuresis in obstructive sleep apnea. That's the mechanism for that. So that's a board question.
See. Now, just like Dr. Weiss mentioned, she was lessening your load for Q&As. I'll take one of the questions, which is from Dr. Sardesai, who said, what causes isolated sleep paralysis? I'll tell you a really quick 20-second story. I was 16 years old. I was going for the first time in a train to my medical college from Kalka. I was going to Delhi, and I was traveling by myself. I was in the upper berth of the train. Had not slept well the 2 nights before leaving home. I was traveling by myself, and I'm lying down. All of a sudden, my body's paralyzed. I cannot move. It's the most terrifying situation. It lasted about 20, 25 seconds. Then it was gone. I've never had it again. And this is actually very common, reported initially in Japan, also in teenagers. I think one paper said about 15% of teenagers, healthy teenagers, can have an isolated sleep paralysis episode. So it's probably has to do with the fact that there is REM sleep deprivation in the previous few nights, and then there is a sleep onset REM, because REM is so hardy, it comes right back at you, and it just happens to intrude onto wakefulness, and you're lying down and you can get that. But it's a very benign sort of phenomenon.
Yeah, so I think it's an intrusion of REM sleep in wakefulness. And I remember when I was in Boston, this huge 6.5 feet NFL player was referred to me for this sleep paralysis. He was terrified. It's like something bad is going to happen to me. My career is gone down the tube. I wake up in the morning, I'm paralyzed. I cannot do anything. And this huge 300-pound guy, 6.5 feet and more, crying to me in the sleep clinic was horrifying. And I said, this is nothing. It's isolated sleep paralysis. Reassurance. And he went back smiling. But, he must have had sleep deprivation too. And so, yeah, to make your point.
Should we have those two? We have only two cases. Should we have those two brief cases and then the
Can I-
Q&A? Or should we?
Shall we do the Q&A
Q&A
quickly
first.
first? And then
Sure,
go to the
sure,
cases?
sure. Vishnu, please read out the question. Please, can you?
Yeah. So, sir, so the first question is, what is the mechanism of confusion arousal vis-a-vis a frontal lobe epilepsy, as they look very similar? So they want to know the pathogenesis of confusional arousal.
So confusional arousal is a form of non-REM parasomnia. You are stuck neither in non-REM sleep nor in wakefulness, and you're stuck in that state. And so you start doing bizarre behavior. Your central pattern generators get activated and you do those things. In nocturnal frontal lobe epilepsy, you have an epileptic related phenomena and the central pattern generators get activated and you do the same semiology that you do in confusional arousal. So that answers that question.
And sir, how are the prevalence of parasomnias different in autistic children vis-a-vis normal children?
Yeah, so I think it's important to differentiate that they may not be parasomnias, they may be stereotypies. And stereotypies are very common in the neurodevelopmental disorder children. And you need to know whether the eyes are open or eyes are closed and whether you're awake or asleep, because you need to address it separately.
Yeah. And then, sir, there is a question on sleep laryngospasm. I think Dr. Kavita wants to know the treatment of sleep laryngospasm. She has just mentioned the term, so I think she wants to know the treatment.
See, usually you have to send it to ENT. Oftentimes it is related to some form of vocal cord paralysis. Once the ENTs have ruled that out, you want to be sure there's no reflux. You want to be sure there's no H-type T fistula. And then if it's really bothersome, with the help of ENT, you can decide a plan of action. But if nothing works, I don't know, CPAP, I don't know what else you do in this situation.
And then there is a question on bruxism. So if it's associated with ADHD, does bruxism need treatment?
So I think Suresh addressed that, giving some iron, obviously mouth guards. I've used gabapentin sometimes, and the bruxism has reduced. People have tried using Botox in the temporalis in the jaw muscles. I don't do it because I'm scared overdose will make you look with your jaw hanging like a stupid person. So I don't do it. But usually a mouth guard. I tried gabapentin. I try some iron, and then symptomatically you may have to treat the ADHD symptoms.
And sir,
Yeah,
how
in
to
that-
different?
Sorry, Basarup, there was a study from Stanford, Christian Gilman was where I think there are a large pool of patients with bruxism. A number of them had OSA, and when they treated the OSA, the bruxism resolved. So looking for OSA is important. And as Dr. Kothari mentioned, iron deficiency too.
So how to differentiate insular seizures from nocturnal panic attacks?
I think, first of all, looking at the semiology. Okay. Secondly, a good EEG with extended, if necessary, even 10-10 EEG montages. Getting a very good quality MRI, 3 Tesla with all the epilepsy protocol. And sometimes we may have to actually do stereo EEGs, putting in insular electrodes and seeing if the seizures come from the insula. Remember, the insula is buried deep inside, and it doesn't cast good EEG things on the scalp EEG. So you have to be really suspicious of it. And your MRI has to be really looked at very carefully. And we have used good insular coverage using stereo EEGs because it has the frontal operculum, the parietal and the temporal operculum, and the deep bedded insula deep inside. So, and those patients are difficult to treat because you can resect the insula. We have used responsive nerve stimulation and laser ablation for these patients, but it's a tough one. And you have to be really vigilant and aware of the fact that behavioral changes, change in heart rate, change in central apnea, change in any autonomic features with a seizure is most likely to be an insular seizure.
So there is a question, sir, like.
Could I just add, because we're
Yeah,
talking
sure,
about
sure.
different resource settings. That I agree with Dr. Kothari's answer, but obviously this is one question that really brings up the difference in resource settings. So, for example, in Canada, where Dr. Ranjith was an excellent epilepsy fellow the last few years, we have long waiting lists, but in America, where you have more resources, you don't have to wait so long for SCEG. And in other countries, you might not even be able to access SCEG. So I think it's a really good thought that this is where resources are quite different across the world.
Absolutely. Absolutely. But I know India, they have very good qualities MRIs. And I think if you get an epilepsy protocol, 3 Tesla MRI with thin 1 millimeter sections and a T1 volumetric and a 3D sequences, you will pick up the focal cortical dysplasia in the insula.
That's
So-
an interesting point that you and Shelley raised. Is ictal SPECT available in India? Because I mean, there's a lot of personnel, and they could be just waiting for an event and just inject the patient during an event.
So let me tell you about the ictal SPECT, the way we have looked at it. First of all,
Yeah.
in the US, the SPECT scans comes at 8 o'clock in the morning, and by
Yeah.
1 o'clock or 2 o'clock, it's gone because it dies
Sure.
away. So you have
Yeah,
to
yeah.
catch that 6-hour window. And you have to have somebody sitting at the bedside with everything connected, with somebody's eyes on the EEG, because in frontal lobe epilepsy, within 10 seconds, if you don't inject, it'll lose its value. For temporal lobe, 30 seconds is a good point. So,
Sure. Well,
It's
in
plus
India,
and
you know
minus
how the families are, and everybody's out there with the patients. I wonder whether ictal SPECT, and maybe Dr. Gulati's team, and you would know more about it. Is ictal SPECT easily available? Is it doable in India or other countries?
It is doable. Actually, when I was doing my residency, that time I had picked up 64 children and I had done,
There you
but then
go.
you need 64 over 1 year. So it was difficult to do, but we do have it available, yes. And now we have earlier we were having specifically for pediatric we used to get, but now actually, yes, once in a week it is there in the nuclear medicine, we can do it. But although that use has gone down, I mean, that time, I was trying to see in a study that was published in JCN actually long back. I'm talking about 25 years back or something. But then it is available, yeah, definitely.
Yeah, and because I'm not an epilepsy person, but I mean, with a epilepsy protocol MRI co-registered with the ictal SPECT.
Yes.
I
That
think
was being done, yeah.
In
that would-
Turkey,
Yeah,
I
actually,
like
it's
that
better to.
document.
Sorry, go ahead.
Now, now it's becoming co-registered to PET. That's why we are not
Yeah.
having, so, in those times when I was getting the ictal PEC, the spec done, that time we were co-registering that time, but now it is generally being co-registered with the PET, right? So,
Yeah, I think with a PET and a MEG gives you more information than an ictal
Yes.
SPECT, which is very labor intensive, and there's a lot of money lost when you don't get it successful. So.
Sorry,
I
I'm
would say the same thing, yeah. In Turkey, we don't have ictal SPECT nowadays. Therefore, we use PET and co-register with MRI also. We don't have stereo EEG in many centers, Dr. Shelley. Therefore, we do 3 Tesla MRI and co-register with PET.
Yeah, and actually here we can do a PET MRI.
Yeah, PET MRI. We do.
No. This is so the PET is done on a CT. What you're talking, but we have a PET MRI. So directly on
Yeah.
one sequence, you can do both.
yeah. We don't have the PET MRI. We have the PET CT, which the images are
Co-registered,
co-registered. Yeah. We don't have the PET MRI as of now.
So few last questions are left, sir. So one is, can parasomnia have an abnormal EEG?
I mean, 4% of the normal population has an abnormal EEG. 2% of the normal EEGs have a photoparoxysmal response. It's benign. The only problem with that is when you are a pilot and you need to get an EEG and your EEG is abnormal, you cannot fly. You cannot fly a commercial airline if you have an abnormal EEG. That's it. That is an unsaid rule. So you can have the answer, but you have to interpret the EEG abnormalities in lieu of the parasomnia event.
And the last two questions, what is the reference level of ferritin? I think which you've already mentioned in your talk, sir. And any role for melatonin parasomnia, I think that has also been answered. So your concluding remarks are on these two.
But only thing is I want to emphasize that pediatricians will tell their patients very emphatically, what is this guy talking? Your ferritin level is 35, you don't have anemia. You have to educate them and say, we are looking at brain iron and not body iron. And brain iron cutoff is 50 to 75, not 20 and above or 30 and above.
And sir, your remarks
should we
on
have
role of,
the-
yeah, yes, ma'am. Yes, ma'am.
Continue.
So there's the last question, ma'am. Any role for melatonin? I think it was already mentioned, sir. Just your
Yeah.
remarks on role of melatonin in parasomnia.
So in general, I want to emphasize that more is not good enough. Okay. So, people will start with 3 milligram, go to 5, then go to 10, go to 15. Anything more than 5 milligram is really not indicated. Many of my Suresh will vouch for this. Chuck Seisler and his group from Brigham, they say even 0.5 to 1 milligram melatonin is as good as 3 milligrams. But in the autistic population, the British people have published a double-blind study that up to 5 milligram is a decent dose. So that could be used for the insomnia aspect of it, but also for REM behavior disorder. For REM behavior disorder, first-line treatment is melatonin.
Yeah. And with regard to the melatonin, the other point I would like to raise is that in the US, only the regular acting melatonin is available, which has a short half-life, about 30 to 60 minutes. Whereas I believe in Canada, and I could be wrong, Shelley, and certainly in Europe, there is a long-acting formulation called PED-PRM, pediatric prolonged release melatonin, which really lasts about 4 to 5 hours. So if you can get PED-PRM, please use that, because I think, children with autism especially, not only do they have a parasomnia, they may wake up for other reasons through the night. So PED-PRM is, I think the manufacturer is Nurim, they're out of Israel. I think that's a better formulation if you get it.
I think the product name is also called Circadin.
No,
CIR.
it's Slanito.
Okay,
It's not
correct.
Available yet in Canada, but it's coming
Nice.
soon.
So,
And
very
hopefully
good.
to India also.
Yeah, very true. Good to know. Thank you.
Can we have 2 brief cases? I think
I'm sorry, I'm going to
Ranjit's,
have to leave. Dr. Gulati, have another call to go to.
Dr. Kotakal, before you leave, your take-home messages for everyone, because we customary in the end have take-home messages. So you please, before leaving, give a take-home message.
Okay. Well, I can't top Sanjeev, Dr. Sanjeev Kothari's take-home messages. The main thing is that parasomnias are common, probably more common than seizures in childhood, and taking a careful, detailed history from the child or the parent is essential, and asking families to provide a video clip of the events that occur at night, that is also helpful. And there are cases who really do need to be referred to a neurologist or sleepologist, and if those resources are available, definitely to use them. And so it's a very interesting field. As Dr. Kothari also mentioned, there can be forensic implications, which is another topic for another discussion.
Yeah.
Thank you.
Thank you so much. Yeah, I look forward to your talk in the next couple of weeks. Yeah, thank you. We will request Dr. Kothari to be the expert. Yeah, thank you so much. Thank you. Thanks. I think Ranjit is also our alumnus actually, and Dr. Mahesh is also alumnus. So Ranjit's resident is actually not well. So Ranjit will be presenting, I suppose, right?
Yes. Yeah.
Ranjit.
Yes.
Yes.
Good
Yeah,
evening.
so he has, he's done his MD as well as DM pediatric neurology from Child Neurology Division, Department of Pediatrics here with us. And then he was in Sick Kids for 2 years for the Pediatric Epilepsy Fellowship. And here you are, Ranjit. And his one of the DM dissertations was on polysomnography in sleep children, in epilepsy children. So we had done in the well-controlled epilepsy and intractable epilepsy and all, right? So yeah, please can start.
Good evening, everyone. And I also want to add, ma'am, I also did sleep training along with Dr. Shelley Weiss during my fellowship. And I went 2 weeks rotation to Sunnybrook Hospital at Toronto for a sleep neurology. Yeah, so I'm going to present you few 2 or 3 cases, just a brief videos, which were referred or on treated already as epilepsy and then turned out to be parasomnias. So this is an 8-year-old boy who was referred as nocturnal epilepsy. He presented with daily abnormal events during sleep, and he gets aroused and appears confused. Sometimes speaks irrelevant, often the things which happened over the day or a day before. He was diagnosed as epilepsy, and he was sorted on sodium valproate and clobazam. And as Dr. Sanjay Kothare was saying, like EEG was actually reported as abnormal from outside. And these drugs did not produce any meaningful response to his events, and he was referred to us for further evaluation. So on further history, these events often occur in the first half of the sleep, more often when he was tired or stressed out, and the daytime behavior is actually fine and no events in the daytime, and no events during awake state. And there was no memory of the events in the daytime. And the events typically last less than 5 minutes. On examination, no dysmorphism, BMI was normal, no pallor, no anemia, or no stigmata of OSA, cardiorespiratory systems is normal, and he did not exhibit any signs of autism or neurobehavioral disorders or developmental disorders. So I will go to the video EEG, and then I will come. Yeah. So can you see the screen of the video EEG? Yeah.
Ranjit, it's not visible. It's not visible.
I think one of them said it's visible.
I can see the EEG, sir.
Yeah. Can you see the EEG on the screen?
Yes, sir.
Yes, we can.
Yeah. So let me show the event first. How do we go to the video? Yeah.
I don't think we can see it.
Yeah.
Ranjit, your
Yeah.
2 screens are coming. We
Yeah,
can
yeah,
just
I-
see your slide with
Yeah.
examination. Yeah, now
Yeah,
we
now
can
it's
see.
good.
Now we
Now
can
we're
see.
good.
Yeah. So we did like as we are talking about resource limited settings, like in many situations we have difficulty in getting a overnight polysomnography because of several reasons. So we are able to get overnight EEGs with a full montage for most of these patients. So we can notice he's in the epilepsy monitoring unit and he's in the entry sleep. And let me play the video first. So the mother is sitting besides. He just wakes up. He appears a little confused. He goes near the mother, although he's not speaking. He's trying a little bit of groping movements are there. He's trying to point something. The mother is trying to speak to him. He is a little bit confused. He's not responding very clearly to the mother. And she's kind of indicating some gestures to the mother. But he still appears confused. And the mother is trying to console him and make him go back to sleep. It's a very momentary event. And then he goes back to the sleep. That's it. So let me go to the video. Let me go to the EEG. So we can see it's an N3 sleep and suddenly he gets aroused. So basically this is an arousal rhythm and we don't see any clear ictal buildup or ictal activity. And we do see some muscle and other movement artifacts. And as soon as the event is settled, he goes back to sleep. And this is a classic signature of NREM parasomnia. So I will just go back to this slide. Yeah.
Can I just make a comment on that?
Yeah. So the criteria for confusion arousal.
Ranjit, Dr.
So
Kothari
episodes
wants
of
to speak
confusion when the
something.
patient is in bed and without any evidence of terror or ambulation. And confusional arousals are different from other arousal disorders because patients often remain in the bed and do not show signs of terror. This is one nice algorithm. Does the patient arouse clearly to full consciousness or wakefulness at the end of the episode? No. Then we go to this arm. Is the patient having a perceived turning or dystonic posture during the event? No. So this clearly shows this is a kind of a parasomnia event. So basically, it's a reassurance. We stopped anti-seizure medications. The parents were very relieved. And these events used to happen daily. So we advise sleep hygiene. And because it was very frequent, we also advise low-dose clonazepam. And he is doing fine. So these are two just short videos. One is an 8-year-old boy with behavioral issues, hyperactivity. He presented with daily episodes of abnormal crying during night sleep. Started on anti-seizure medicine suspected to be seizures. The next child is a 7-year-old boy presenting with prolonged unexplained crying spells during sleep. So I will just show the home videos. This is the first patient with behavioral issue. He had hyperactivity in the daytime. So I will just play the other one, which is a little longer. Probably I'll just say 30 seconds of this one. He got up from sleep and he's speaking and a little bit confused, and now the night terror will start. So this goes on for a few minutes and then it settles. The mother knows he is very well terrified. So that's why she's asking him to invoke the name of Tamil god Muruga Muruga so that it will settle on its own. So these were night terrors. And again, we stopped anti-seizure medications. So thanks, Dr. Shelley Weiss, for joining. This is one of the pictures which took during the fellowship. Thank you very much for the opportunity. Yeah.
Thanks, Ranjit. We can ask Mohan to present the next case, which Vishwarup was moderating, right? Mohan is doing his.
Yes,
Can I make two quick-
Sorry, I forgot. You have to make comments.
Can I make two comments?
Please, I'm so
Two
sorry.
comments.
Yeah, you all have to make comments.
So in the first case, I just want to emphasize that, as I have shown in my slides, non-REM parasomnias happen out of stage 3 sleep.
Once again,
But there
Mohan,
was-
stop sharing, Mohan. Let the discussion continue. Mohan, stop sharing, please. I'm sorry. Please, Dr. Kothari. Yeah.
So, as I showed, non-REM parasomnia, as in your case, that comes out of stage 3 sleep. There's a very nice paper from the French group that frontal lobe epilepsy is preceded by a spindle. And that should tell you if a spindle is preceded by arousal, it's more likely to be a seizure if you're suspecting frontal lobe epilepsy. So that's the differentiating point. My second point is, again, I'm being a little cynical, but I would not put on clonazepam because then you don't know whether you're treating the epilepsy or the parasomnia. So I usually do not use benzos when I'm suspecting epilepsy because then it hides the whole process. I would have used amitriptyline or something else to take care of the frequent parasomnias rather than the benzo. That is my comment on the first case. And the second case, there is an entity called episodic nocturnal wandering, which is a form of nocturnal frontal lobe epilepsy. And it is possible that kid that you saw confused had episodic nocturnal wandering. So you have to be really sure that you're not dealing with frontal lobe epilepsy in this case.
Thank you. Dr. Shelley, want to add something? Any comments on the cases?
I think because of the time, I'd rather hear the next cases.
Okay. Yeah, thanks. Many. Mohan, can you present, Ibru, you have anything next? Ibru and Eman, anything?
No, I
Anything,
agree.
or we can
with
do it in the
Dr.
end?
Ferry. Yeah,
Mm,
I
yeah,
agree with
yeah,
Dr.
okay, thanks.
Ferry about all them.
Okay.
Good evening, Honorable Says whether my screen is visible and am I audible?
Yeah. He's the DM pediatric neurologist training with us. Yeah. Mohan.
Mohan, it will be great if we can see you as well. Can you, I mean,
Sir, okay, sir. Good evening, respected seniors and dear colleagues. Today, in continuation of today's discussion, my cases will be a 3 case scenarios. The topic will be the paroxysmal events in sleep, the neurologist dilemma, where I'm going to discuss the 3 case scenarios where a detailed clinical history and home video and the judicious use of investigation helped in clinching the diagnosis. So let's move on to the case. So moving on to the first case, here we have Master P, a 9-year-old boy who is a case of recurrent MOGAD under our follow-up on immunotherapy, had come with the complaint of 1 episode of paroxysmal event. This is the event. He got up immediately from sleep within 30 minutes. Looking confused, followed by walking around with repeated whistling with incoherent vocalization. This was the video was shown to us, and with this clinical history and a background video, possibilities considered were in non-REM parasomnias, sleepwalking, and non-motor seizures with impaired awareness. Subsequently, we did an EEG where we can see epileptiform discharges, spike discharges arising predominantly from the frontal region, that from the right frontal region, where we can see a epileptiform discharges from FP2 and F4. So with this EEG, and we diagnosed as a epilepsy, and we started him on ASM, and there were no repeated events. This is the first case. And moving on to the, and subsequently in the same epoch, we could see the runs of discharges, the epileptiform discharges continuously arising from FP2 and F4, preceded by a sudden change in background. So which could be consistent with the ictal rhythm also. So with this findings, we are sure that it is an epilepsy, and we started him on ASM. And after that, there are no such episodes. So moving on to the second case, who is a 2.5-year-old boy who was presented to us with the complaints of frequent nocturnal awakenings with incessant crying that has been persistent for 2 months. And this is the video. There is an incessant crying, and we can see now there is a stoppage of crying, and there will be a brief episode of vacant stare. So there would be a brief episode of vacant stare, and again the crying starts. So this was the case referred to us as a night terror, but after seeing the video, we kept the possibility of an epilepsy, and subsequently EEG was done, which also showed epileptiform discharges in the frontal region from F3. So this case was also diagnosed as a case of epilepsy and was started on anti-seizure medications, and he is under follow-up, and there are no further episodes. And moving on to the third case, he is an 11-year-old boy who presented to us and was referred to us as a case of epilepsy. Again, an evaluation and the videos, there were a sudden jerky movements. This was the events. There. So first I'll show the videos, then I'll describe. So before going into the sleep, he started having this paroxysmal events in form of walking, that immediately after lying on bed. And we also noticed there were some sudden jerky movements. and he used to walk with eyes closed and all. So based on this history and these videos, the possibility of psychogenic non-epileptic event was higher on records, but even though it was the first episode, so we wanted to rule out an epilepsy, and EEG was done, and that was turned out to be normal. So when we again took a detailed clinical history, these episodes were associated with the school absenteeism also. Then then detailed psychology evaluation was done, and he was diagnosed to have a learning disability, that was SLD, and he had a school stressors also. So this stressors precipitated this psychogenic non-epileptic event, and the final diagnosis of PNE was made, and parents were reassured, and the behavioral intervention and psychological interventions were ensured, and he is under follow. So these were the 3 clinical case scenarios, and our take-home messages is the commonest differential diagnosis for parasomnia with treatment implication is a frontal lobe epilepsy, and in all these 3 case scenarios, the detailed clinical evaluation, along with the home videos, along with judicious use of EEG, helped us in reaching the diagnosis. Rarely, psychogenic non-epileptic events also mimic parasomnias. Then we should, then the timing of event, the factors like timing of event, semiology, like complex, which is not fitting into any seizure semiology, and associated stresses have to be considered, especially in the childhood age, to differentiate from parasomnia and to be very sure that it is a psychogenic non-epileptic event. Thank you, Anand.
Thank you, Mohan. Before you, Vishwarup, you can make comment. Actually, Dr. Shelley is leaving. So before she leaves, stop sharing, Mohan. She can just give her take-home messages or any comments on both the cases. Before Vishwarup, you give your comment on the case. Sorry. Dr. Shelley, please.
Sure. Thank you. And sorry, I have to leave to another meeting, but Dr. Mohana, thank you for those great cases. And I think they really illustrated the whole talk of today, which is that a neurologist dilemma can be solved in any part of the world with like a good history, exam, EEG. And even though obviously some cases can be difficult and we need MRIs and MEGs and PETs and all the other sophisticated investigations, I think a lot of children who have query sleep disorder or epilepsy or both, with sleep, we can actually sort out with history, physical exam, EEG. So thank you so much for inviting me to participate. I'm sorry I have to leave.
Thank you. Thank you so much. Thank you very much.
Okay.
Thank you. Vishwarup, your comments before we open for the final comments from everyone. I think we have crossed 5 minutes. Yeah.
Yes, ma'am. Thank you. So again, I'll just reiterate whatever we have been, talking throughout the session today. So home videos, very important, but we have to look, take care of the safety precautions when we are recording the home videos. And secondly, the timing of the event is very important. So if you look at the first event and the second event, both of them were happening very early into the sleep. So the child was falling asleep, but were happening within 30 minutes, 40 minutes of sleep onset. On the other hand, the third one, the child was not even falling asleep. He was just lying on the bed. And even before going off to sleep, he would close his eyes, and within 5-10 minutes of lying on the bed, he would start having that, getting up. And what was interesting was he was roaming around with his eyes closed and having those searching movements with his hands, which made us suspect, that this could be psychogenic. And then we looked into the history and found that he had a learning disability and there was academic pressure for last 3 months. So along with these events, he had associated school absenteeism as well. So just to reiterate the fact that, ma'am, good detailed clinical evaluation, home videos wherever possible, judicious use of investigations, and very important to differentiate parasomnias from parasomnia mimics. That's it from my side, ma'am. Thank you.
Thank you. Dr. Kothari.
I think, I think we have belabored the point again and again that one should be able to differentiate these parasomnias by, again, a good history and home videos. And again, safety and legality is very important, especially in your teenage population. They do bizarre things, and you want to be sure that it doesn't extend into some criminal activity. And separating front lobe and insular epilepsy from parasomnia is very important. They can coexist. A good thin section MRI is possible. And start with simple things. What I do for my simple night terrors, I give a little bit of nasal steroids, a little bit of iron, and a little bit of melatonin. And Dr. Chakraborty has seen that regimen work so well in my patients when he was here with us. Just this triple combination, whether it's a placebo effect or it's reality, it's hard to say, but it works. So that would be my two pieces of advice.
Thank you so much. Thank you. Thank you, Dr. Ebru.
Thank you, Dr. Gulati. And my final conclusion is that if we have patients who are experiencing these severe episodes of motor activity during sleep, the first thing that we have to do is thorough neurological assessment, and we may sometimes need to require some neuroradiological assessment and video EEG also. This is very important because these disorders can be manifestations of epileptic or non-epileptic conditions like parasomnias, and the treatment is really completely different in these disorders. Therefore, it's really crucial to clarify the diagnosis to differentiate between them. These are my final conclusions. Thank you.
Thank you. Thank you so much. Dr. Ahmed.
Yeah, yes, thank you very much, dear Dr. Sanjit. These are very good cases. The last case of psychological manifestations of mimicking the sleep disorder. Like all my seniors who have given the final comments, I would emphasize on detailed history, detailed semiology of the event. This is very important. We have to investigate these cases just like we do investigation of epileptic event. We have to take the pre-ictal event. We have to take the detailed history of ictal event and what was the post-ictal event. Then we have to differentiate, yes, this is non-epileptic event, and then we have to start the medication because the treatment is entirely different. But although we are living in an era of PSG and PET scan, but we have to stick together with the history and detailed semiology. Thank you very much.
Thank you. Thank you. Dr. Vishnu, your comments, and there's some two questions for you.
Yes,
cases.
ma'am.
Yeah.
So the first question was the recurrent MOGAD related to EEG findings and what was the MRI finding? So yes, the MRI, this was a recurrent MOGAD case, and over a period of time, new lesions had come up, and actually lesions were there on the right basifrontal area and also on the right occipitotemporal area, and the discharges were actually from the right hemisphere only. So yes, there was a correlate between the EEG discharges and the MRI findings. And did we have ictal changes with the episodes along with the interictal changes? So the events were not very frequent, and these EEGs were short EEGs, short duration EEGs with all protocols followed, awake with all activation procedures and sleep EEG. So no ictal events were recorded during this time. So these were all interictal changes that we had recorded. So that's it from my side now.
Thank you. Mahesh, you want to say something? Yeah, say Vishnu somebody was saying.
But
Mahesh,
we
yeah,
have
please.
to keep in mind that 50% of nocturnal frontal lobe epileptic events, they can have a normal EEG even in the ictal state. So we have to give a leverage that if there is seizure, EEG can be normal in nocturnal frontal lobe epilepsy.
Thank you. Mahesh?
Yes, all the guys were very challenging. Only advice, my point is that if you advise proper sleep hygiene to all these babies, that is one of the important trigger for this disorder. So, while advising parents sleep hygiene and reducing screen time, these advice have to be to all the patients.
Yeah, thank you. Thank you. I think that is coming up now in a big way. Earlier, it was a very neglected part in our country. Now it is coming up. But anyway, at the end of the day, I think history taking and having the description of the events with those videos are very, very important. And that is very, very important and been very highlighted. We're very grateful to Dr. Kothare and all our panelists for joining, and wonderful cases, Ranjit and Vishnu. Well presented, Mohan. I think thank you so much. So we will look forward for future meetings in the future, and reminding again you for the AOCC and next year. Thank you so much.
Thank you very much for having me. Thanks a lot. Have a good day.
Thank you.
Bye.
Bye. Bye. Bye. Bye.
Thank you.
Thank you and bye.
Bye. Bye. Bye.